Good morning, good afternoon, good evening, depending on where you are. I am Tine Hansen-Turton and have two roles. I'm CEO of Wood Services, which is our large population health management organization that serves kids and adults with intellectual disabilities and severe medical complexities and behavioral health challenges. And I also serve as executive director of the Convenient Care Association, which is a group, an association of health centers that are in retail settings that are run mainly by nurse practitioners. Today's topic is the evolving role of nurses and also the whole idea of population health and social determinants, and what is the care team beyond physicians that needed around the globe to really address both health issues, but also the social determinants and all the other factors that really makes for an approach that aims to improve the health of an entire population. Today we have with us an incredible lineup of speakers. I'm going to turn very shortly, the mic over to each of them so they can do an introduction, and then we'll jump into some questions around that evolving role of nurses and others on the healthcare team. So first, I'm going to, introduce Francis Hughes, who serves as consultant and do a consultancy with Cockfin. So to Vibeke Westh, from the Copenhagen Nurses Association, just to do introductions about her role, and then we'll turn over to Aricia and come back to you, Francis.
Okay.
Vibeke?
Hello, my name is Vibeke Westh, and I am the chair or the president for the Copenhagen area, the capital region of the Danish Nurses Organization. I do that full time. I'm elected for this position. So I have been involved in union work for many, many years. I also sit on the board in a steering committee who works together with WHO Europe on the behalf of nurses and midwives in Europe. So I'm very much involved in all these things. As a president here, I'm also on the board for the educations for nurses and midwives and other ones. So I'm very much involved in education issues as well. So that's a brief introduction to me.
Great. So Aricia, you want to introduce yourself?
Hi everyone, I am from Belgium. I am a Belgian midwife. I've had work experience in Gambia. I went to Finland for an internship. I worked in the UK and now I'm working in Belgium. I'm working in a low-risk birth unit within a hospital. It's the first one in the country where you actually have a birthing house within the hospital, which provides the security of the hospital, but gives you the possibility to work as a midwife and do natural birthings, as well as doing the prenatal and postnatal follow-up. I also work for the Network Towards Unity for Health. I am the program coordinator. I am the lead for the conference organizing, and I'm in charge of a membership platform. So you probably already met me through email or through Skype.
So it's great to have Aricia speak about her sort of professional, work today, and also I think it's great. So we have the other half of the network with us. So wonderful. All right, Francis, let's turn back to you and see if you got a better connection.
Sorry about that. I'm Francis Hughes. I come out and I'm a New Zealander. I worked in New Zealand and in Australia and Queensland particularly as the chief nurse. And with that, I had the responsibility of working with the government and influencing the government on literature and research in advanced practice nursing. This resulted in working with stakeholders in both countries to develop policy and implementation and support legislation and service models for nurse practitioners and advanced practice nurses. Within that involved nurse practitioners, nurse prescribing, and lately in Queensland, the roles of nurses undertaking very advanced technical procedures such as endoscopy, colposcopy, and also the role of nurse navigators.
So I'll frame, we have several questions on the panel and for the panelists, but let me sort of frame the discussion for us on the panel today. If you detect an accent, with the when I speak, it's because I'm also Danish by background. So perhaps I had the fortune of growing up in a country that really puts together nicely both medicine and also social determinants, which essentially are all the other support factors that really impact behavior, or sort of, how healthcare is impacted. So if you remember when you look at sort of healthcare services, really only 20% of healthcare, can be accounted for in terms of the delivery of healthcare. So much more is environment, but more importantly, behaviors. And I would say those behaviors, are impacted with where you live. If you have, a roof over your head, if you have education, if you are, your socioeconomic status, all those other things that impact, healthcare in general. And that takes a lot more than a healthcare, I would say, the typical medical team that's part of when we think about healthcare delivery services. It really takes an approach of multiple providers, some layout workers, nurses that are professionals, physicians, and other workers. So I'm going to open up the question for everybody here. And what is the team from your perspective in the countries you're in, what you've seen around the world? Most of you have worked in healthcare around the world. What is the team that's needed really to address population health?
I mean, it's if you look at Scandinavia and the European countries, we're very happy to be in this part of the world where actually our healthcare system is very well developed, and we have free and equal access to most of the healthcare systems and services as a rule. If you become ill, it must be the amount of you. It's not your income who kind of does it. It has actually, you have still access to have the treatment, and to healthcare is available for you. But however, despite this privileged position, we have a lot of things we need to address here in this country. So, and it is that we face quite a lot of things where, the survival of cancer, stroke, diabetes, heart diseases, and people in this vulnerable situation actually needs to do something about it. And we also have a well-known social determinations, which is really very bad for the population. Despite that the healthcare system does not account for the main social causes of the significant increasing inequality in healthcare, we must provide all patients with serious possibilities to cope and live with one or several chronic diseases right now. Nurses and other members of the healthcare are ideally positioned to play a vital role in adjusting and tailoring holistic care to the specific needs and values for vulnerable children and patients at most risk. Both in the primary and secondary care, and in the interfaces of primary and secondary, including at schools and in the patient's own home or immediated environment. Therefore, I have the Danish Nurses Organization, together with other key role players here in Denmark, joined in a venture on fight against inequalities in healthcare. We recommend following things. Primary and secondary care must expand evidence-based effort to bridge the many efforts of fragmentations of care. It needs to have that we have APN nurses with an expanded authorities, including advanced knowledge and skills in coordinating and communication. They are key role players in this. And as I told you before, we have a struggle about that because we don't have it right now, but it's coming up, the education for primary health care. Primary and secondary care are committed to disseminations of evidence-based methods and multidisciplinary approach to establish and improve partnership and cooperations to patients with special needs, such as shared decision-making. The government is obliged to fund contributions to improvement of patients' health literacy, and nurses and other healthcare professional knowledge and skills in improving patients adjust their communication to individual needs of patients. But also healthcare visitors with advanced education and expanded authorities plays a very role in this one here. Early identifications and interventions of children at risk, including supporting participation in screening and vaccination programs, and to support and guide families with special needs in their homes and immediately environment to healthy lifestyle during childhood. And for the last, we think we need to expanding the role and number of specialized social nurses with expert knowledge and education about marginalized persons in special needs. This type of nurses are extremely important with regards to the case management patients with a complex need, including problems with drug, alcohol misuse, homeless people, and etc. Furthermore, they are important role models for ourselves to mentor and navigators for the multidisciplinary teams involving in these patients, both in primary and secondary healthcare. So that would be some of the issues that we have addressed here, and I think will be, so I look forward to the discussion.
So one of the things, a couple of strikes, so certainly, addressing having a workforce, nurses and others that understand and have the skills, knowledge about individual care needs is what I hear, and that's a big part, and I agree. And I would say, and also folks that understand, what's the environmental factors. Actually, I'm located in Philadelphia, and Jefferson University has a global conference in town around population health. So last night I got to spend some time with folks from around the world, and even in America, where I live now, it was a simple thing, but the studies now have shown that some of the postpartum depression in women that we know they're low income have to do with the fact that they can't even afford diapers. So simple things that are more economical, that goes to that social determinant you mentioned, Vibeke, has a lot more to do with what does that impact your lack of access to, whether it's again housing or things you can't afford for your child, or if you're an elderly, things you can't afford for yourself. That impacts your overall health and also your mental health. So I think really key things and having somebody who understands that. So with that, Frances, you want to try again?
What we're facing is a tsunami of non-communicable diseases. So we've got the tsunami of chronic diseases, and these are all lifestyle related, which means that there is a huge prevention, but there's also huge ability to turn the consequences around. Even though we might not stop some of the damage that's being done in the bodies by our diet and our lack of exercise and our consumption of alcohol and drugs, which is also causing part of it. We need a team that can be very person-centred. So this isn't the normal provider-driven one model fits all. This is a team that's very person-centred, that relates to the individual where they are in their life and in their location. So we need a mobile workforce that can work to prevent hospital admissions, can work predominantly, I believe, in the community, working in primary care, yes, but the true primary care definition, which is wider than just medical intervention. So we're talking about, as we've heard before, around those that can deal with the social issues. We deal with the people, we deal with the housing, the unemployment, the issues around education, the issue around access and affordability. And it's no use giving people drugs if they can't pick them up from the pharmacy because they don't have any funds. So the team in the future is really that whole comprehensive nature of working with people at their level, which means that we need people to work with that kind of social paradigm. We need to be able to have people that can work with the behavioural aspects to help do motivational and understand what is occurring in people's lives, working a lot with anxiety and people with distress, because we know that a lot of that is triggering some of the early mental illnesses that we're seeing, and also generating some of the negative coping mechanisms that are occurring. We need teams that can help build resilience in our communities. And resilience, what's going on in the political nature, in the environment, in the climate, and the challenges of workforce where people are working is not going away, but we need more resilient communities. And with that, of course, we need early intervention. So we need good assessment, working with people to understand what it means for their bodies, what is occurring. We need to have good access to good diagnostics. We can't be waiting months for diagnostics of basic things like for diabetes, heart conditions, things of we need good nutrition, and we need to have and good pharmacy, because one of the problems that I think is occurring is as we've got more and more disorders and diseases that have developed, we've got huge issues now with polypharmacy. And some of the drugs also create their own consequences, and then we get more drugs to combat that. So there's a huge role here for nursing. But nursing will partner with other key health professionals. I think they've already partnered for years, of course, with medicine, but I think medicine will start to create greater specialist roles in primary care, and the nurses will start to have a more comprehensive role in primary care. Nurses and nurse practitioners in particular will start to take up a lot of the areas which is unmet need. So this is not about competing with other professionals. This is about dealing with this huge unmet need in our population. And within that, educating, so that all the psychoeducation or the patient or the family education, these are huge, big roles for nurses. Working with pharmacy, working with physical and physiotherapists who understand the issues around what happens in your body through bad work habits, through accidents and injuries. A lot of these areas are neglected. Many people front up to our A&E departments with myocardial infarcts, and in fact it's anxiety, it's panic attacks. Many people end up with severe back pain, joint pain, and it's not because they have got necessarily a bad disorder, it's often because of ligaments and bone and joint issues, which can be absolutely dealt with by physical therapists and physiotherapists. So I think there's a whole new team. At times they don't work all together, but they need to be able to refer and have really strong relationships. And, the biggest thing is to keep people functioning, keep people out of hospital, out of those very, very acute services which are already in demand. We cannot keep continuing to build beds and investing in infrastructure. We should be actually investing more in the community and community health. And that's where the team will be. And it will be a different team. And the patients and the community need a lot of education about how to utilise some of these practitioners differently, because the old things that they thought they'd go to a doctor for or a nurse for are going to change. You're going to find nurses and other professionals in the apartment buildings where they live. You're going to find them in different locations and more mobile.
Aricia, you work with women as a midwife. So from your perspective, what do you see as some of what's needed for population health and for that population? And I think sort of the core I've heard from both Vibeke and also from Francis is really the individualized person-centered needs. I mean, somebody who understands, really, what goes on with that person they're dealing with, which is a huge, I think, responsibility. And I would say you see women at the most exciting part, I would say, of their lives, but also sometimes the most vulnerable for those of us who are moms. So we'd love to hear your comments.
Yeah, thank you. So I think what we're looking for a team, and following up on what has been said, indeed, we have to focus on what the patient needs, on what the community needs are, because of the fact that every person, if you look at midwifery, every mom that is about to be a mom, every dad that is about to become a dad, has different needs, has different questions. Some need 20 lessons to feel prepared for giving birth. Others just read a leaflet and feel completely confident with themselves and do it that way, which are both fine, but you need to adjust patient to patient, community to community. Looking at the team that should take care of it, I think it's very important to see the strength in a multidisciplinary team where you collaborate on the same level, and there's respect as well. There's no hierarchy of who is in charge of who. It's a collaboration. For instance, in the center where I work, we work closely with gynecologists, physiotherapists, we have psychologists and psychiatrists, and then sometimes we work with anesthetists and whatever is needed, as well as pediatricians. So there's a very broad group of people that all collaborate towards the same vision. We have a person here, a couple that is being followed, and we want to have a normal childbirth at the end of it. Sometimes complications can arise, and that's the case that we need to all see what are our responsibilities and also what are our boundaries. So it's not that we are going to fight one another about this is my job and that is your job, but we should all collaborate, and that's working within what is your field and also being able to see where the limits are and refer to those next to you. So to ask a question to a gynecologist because it's a medical issue that you don't have much experience with, because you have to know that after childbirth this child will need particular help, so you go and you get the pediatrician involved so that they can prepare the couple as what is to come. So it's seeing all of those persons that have their own specialities and then working all together in the same optic. I think that's the importance. I think it's also very important to look at the intergenerational teams that we can have, working with young students or young medical professions and using those who are of a very wise age, who've seen it all and done it all. That's a very important key within the team, because we don't want to be losing the excitement of the young people that want to learn and want to do, and we don't want to lose the wisdom that will go when people go and retire. So it's very important to also link those people together and learn from each other, because both the older generation and the younger generation can learn from one another. Where in the older generation you have wisdom and experience, the newer generation brings new technology that sometimes the olders don't have, and the collaboration within that generational structure is really interesting to see. And I think it's very important to start that kind of collaboration, both intergenerationally but also multidisciplinary within the education itself. I did a master's myself in health promotion, and during the master's degree, we did projects together with medical students that were studying to be either generalists or other. And the fact that we worked together within the community to do some brainstorming about what the issues were, and then working together, actually made them realize as medical students the value of nurses and the value of midwives and the value of collaborating, because they see it from one point of view and they haven't maybe thought about the other side. And so while working together and being open to that within your education, moving forward as you then graduate as a medical doctor, you would also see the value of having a nurse and having the responsibility of that nurse being bigger than just, well, do what I tell you, and see the value of that experience so that we can all work together and respect each other, instead of just assuming, well, I am this person, so I know more and this is what will happen. But listen to what other members of the team have to collaborate, because it's not that I'm a midwife, that I have all the answers. If it's a mother and there's maybe a physiotherapist that comes up with what this woman needs, that's definitely as interesting as it could be. So just working all together.
Great. So, and I would say that, from a perspective, sort of looking at, really, we have three generations. Aricia, to your point, we have three generations working in the healthcare workforce now. And I would say what I'm seeing, at least from what I know, is that the education now, the younger population, so your generation, what we call millennials in the U.S., you and who's coming after, so that generation, I would say, a lot more team-based. I think there's more of an understanding of the fact that it's not hierarchical anymore, that you need to be a team. But with that said, we still do have hierarchies in healthcare, and I think that, at least what I see in some countries, are barriers to doing some of the things we're talking about, which I think it sounds really needed, it sounds good, but how do you spread that to the rest of the world? And so I'm curious, we talked a little bit more about more skilled workers, nurses, nurse practitioners, midwives, doctors, and more professionals. I'm just curious to see, and I'm going to open up to all of you, how do we broaden and strengthen the healthcare team that perhaps is not the educated team? So I'm thinking community health workers. I worked for the last 30 years with community health workers that are essentially people in the community that we hire, we train them in a curriculum, or they become sort of navigators for the community, but often know all they don't know, I'm not sure everybody understands to call it social determinants, but they know that, uncle this and, sister this and that, have these issues, and that's impacting them. So they're a lot closer to, I guess, that individualized need of, what's the person living through that's impacting their health. So how do we strengthen that team, the community health workers, maybe as an entryway, Indigenous health workers, and what's the role of other, people in the healthcare team that perhaps are more in the community, whether it's urban, rural, or what we call suburban here in the U.S., that can be part of that team, and how do we work with them? Because I think that they're not necessarily trained in universities. They're trained in the community, and quite frankly, we need them more than they sometimes need us, because they're closer to what the needs are of the individuals. So just curious what you guys, how we broaden that team.
No, I mean, it's quite interesting to see how many of the system of healthcare has been, put together in the countries around the world, because for instance, in Denmark, we have nurses, and then we have nurses helpers and assistants, and then in the social field, we have even also social workers, but we also have uneducated persons, and I think that's what you're kind of addressed, Tina. How do we do these things? I think it's also has to do with the mindset about how are we developing both social and healthcare systems for the populations in our countries, because you need to meet people in other skills. And I can tell you that here in Denmark we have turned it around, because we now have nurses called social nurses, and they have actually been going through a political states where we actually put them in, but they also kind of go into the systems and meeting these patients or the citizens in another way, like as a person, and see what is your need, how can we prevent the things, how can we do it. But we also have quite a strong social system here in Denmark, who kinds of also have to work together with the social systems in how preventing that you don't get unemployed, how you don't get, in all these phases of your life. And I think what it's nurses and the mindset of about how can we prevent things need to go into these systems too. And that's a really difficult things. And we have to make the good stories out of how we can make a difference, because right now a lot of these persons who works in the fields that you kind of addressed, Tina, is the low persons in our systems. They're poorly paid, they don't have very much education, but also they are not recognized for actually doing a lot of the work which is within the citizens. So I think what we need to do is like get a higher level of education, but also addressing what is it actually you can do in the fields where it's not highly, it's also about resources, but we can get back to that point later on.
Well, I think that's a good point. And I would also say that the role of volunteers, so I know in Denmark, I have a first-hand experience with my 84-year-old mom, where the role of volunteering, and she's got a visiting friend, as she calls it, where you got, really a person who socializes with her and comes to her every week, and she looks forward to it. And that's really, that person is part of that team too, because it plays into her individualized needs and not to be socially isolated. So I think that it's a broader team.
I think with the team of the future is not necessarily a healthcare team. Because we're going to be and we should be putting, as we've mentioned, all of us, putting the person at the centre. Whatever evolves around the person to provide the supports, whatever they need, to keep maintaining their functioning the best way they can, will involve people who are trained health professionals, regulated health professionals, but then there's this massive group of people who have always been there, but often we've never really legitimised. And these are people who are, as you've said, the volunteers. You get people, and I've worked in mental health and disability majority, who are like peer support. They're people who have similar conditions or are there to support them and understand them, and that's a peer support. We have those workers who are paid and employed by agencies, and maybe the healthcare, but maybe a social agency, who are called community health workers, and they are people often who understand the system. So they often understand the agencies, and they can guide and support people to do activities of daily living, things like shopping. They can help with, we can have a network of people they can help, where they will bring in others like cleaners and people that can help with gardens and all those kind of people. So there's a whole world of people out there. But if people are employed and paid to work with vulnerable consumers, and also if people volunteer, there should be some mechanism to ensure that there's no ability or they are screened in some respect. It's really important, because I think if you are providing a service to individuals who are vulnerable, then must be mechanisms to screen and to ensure that they are not exposed to any sort of abuse. And so I know that we say they're not trained, but the area is we have an obligation, if public money or if there's funding going to support individuals to work with vulnerable consumers, that there is a degree of orientation and also basic codes of conduct and how you work with people in their own home. I think we're all seeing the age population around the world being very exposed to abuse. And I think we need to be very careful. So yes, there's a massive group of workers, and we need to involve more other support type workers with consumers. But as a health professional, we also need to ensure that they understand what they're doing, when they're doing it, and also that there is a degree of education, but more so that there's a code of conduct about how to work with consumers. And there's a contractual obligation, a social contract when we work with vulnerable consumers in the community. So it's more so than in a hospital.
Right. No, I think this goes nicely into my next question for the three of you, which is really, for all this coordination, what are the criteria, standards, and maybe structure that's needed to really to adopt, and there's one that's maybe certifies the healthcare team, but it's broader than that. I think you mentioned a code of conduct. So for the volunteers, what is it that we, how do we assure that people at the various levels that can be part of the care team, really have some standards they meet? So just curious, from are there some universal standards that you can think about, criteria and standards and structure that's really needed to create this comprehensive team, which I would sort of based on a conversation is, the professional team, which is broader than physicians. It's the workers that are not educated, and then it's the volunteers, the people that could be family members or it could be volunteers, whatever they are, that really, take part in that individualized healthcare team.
WHO's put out a document around standards for community support workers. It's a very general document, but it gives you a frame up of what's expected of all people who provide support kind of work in communities. Most countries that I know of in the Western world have a basic kind of certificate for people who do, you might have credentialed certified nurse assistants, or you might have community support workers, or whatever they call them. There's usually a baseline certificate that many countries are now offering. Now, often that is not required for employment, but more and more so, I think we are requiring this kind of level, a base level certificate. Now, a lot of that is around working with consumers and, privacy, confidentiality, things around their role in relationship to working with other health professionals, how to refer people, how to understanding community systems, involvement with families, because it's a very privileged relationship to be actually working with consumers. And so these basic standards and codes are quite important. But they are often inconsistently applied across the continuum within countries. So you'll find that they might be very strong with disabled people, but they're very weak with mental health consumers, or they're very strong with people that work in hospitals, but they're not that strong in people that work in the community. And I think we've still got a long way to go. We're not trying, I think, to create everybody into a health professional, but I think there is an unspoken rule about standards for everybody who works with clients and consumers and patients. And yes, as regulated health professionals, we have codes of conduct, we have professional standards, and we can lose our license if we do things. So, I think we have to have the same kind of framework that ensures that consumers are protected regardless of who comes into their home. And they need to have an understanding of what a health professional will do, what their role is, and within that what a doctor does, a nurse does, a midwife, etc. And what a person who is a volunteer does. You still have to have agreements, and you still have to have an understanding. Consumers have rights, and I think the days have gone of just letting anybody loose in consumer houses and giving care have gone. They're too vulnerable.
So what I'm hearing is this more structure in the community. So Aricia, I'm curious with what in Belgium where you are. I mean, what's your experience in terms of criteria and standards that you see your countries, the European Union, are needed?
So the standards and the criteria amongst most of the hospitals in Belgium in general will remain the same, but there are some little adjustments being done depending on where we are. For instance, in the health center where I work, because it's a birth center within a hospital, we do have our own separate standard of criteria and standards to adhere to, because we do it a little bit different than the general population of gynecologists and midwives do. So we do change it. And I think that's an important value as well, next to the point that Frances was making about the protection and kind of still educating them. Like she said, we don't want to make everybody a health professional, but whoever becomes part of the team and takes this important role, because they are very valuable, all of these community health workers, indigenous health workers, because they know things that we as an outsider will never know and we can never relate as well as they would. But to make sure that they have a minimum of training of specifically more the codes of conduct, as she was saying, to respect people going into their home and to protect people as well as involving them in community decisions. In when we are talking about cases, making sure that they're also invited to meetings, that they're also in the process of creating these specific codes of conduct, these criteria and standards. I think it's also very important to realize that although the WHO document is very interesting, it remains general because it's from the WHO, and I think it's important for each institute, each community, each health worker to look at where you are working and then to amend and adjust and add on what is needed, because what is acceptable and a particular code of conduct in Belgium would be considered rude if you would implement it in a region in Africa. So I think it's very important to also be sensible about the cultural differences that exist around the world, and to make sure that we are taking that into consideration as well when we are brainstorming about how to set up these rules of conduct and criteria.
So Vibeke, in Scandinavia or Denmark, I see a lot of structure and like I mentioned, my mother with her, volunteer, but in her home, and she's cared for in her apartment in Copenhagen. I see a team that seems to be working together. So is that something Denmark is ahead of the game with the rest of the world? I don't know. Or are you implementing the WHO standards? Can you speak to that? It seems to work, at least what I can see.
Yeah, I think we are on the way, but it also has to do with, in certain ways, of the population's needs. Like if, for instance, this is home care, or is it the health care for the elderly, or I think we are going the right pathway. But I mean, what I would like to address is all the social things around, like also Frances says, what is it actually a society can provide for patients and then for the persons needing things. And you need to do different things from that point of view. And that's a struggle because right now healthcare in hospitals is on the line. Cancer and all the other things, diagnosis is very much into where the money are. But on the other hand here, like mental health care or mental health diseases, and we're facing a huge population here who has mental diseases, but they also have diabetes or other chronic diseases, and they don't live long enough compared with the rest of the persons in Denmark. So I think what we should do is we should try and get more effort on what is actually going to do, and that's what is in primary healthcare and out in society, because you need to make up teams in different ways. And this morning we had a meeting here talking about education for nursing, and they told a story about that actually at home care, we have a patient here, and he is a heavy drinker, and he has been really like a lot of stuff that has happened around him. But because of the nurses come every day, half an hour, they prevented him for now a whole year not going back to heavy drinking. So it was prevention. Like instead of now is very much in the drinking position, he would end up in hospital and everything. But how can we transfer the system so the money will be there to prevent instead of, the causes? And I think it's a small issue on some of the things. And what also is concerning here is the youngsters' mental capabilities right now. A lot of stuff around, and I think in a lot of Europe countries, is that our youth is more fragile in some ways, and how can we actually prevent helping them out in the way of becoming, citizens and whole persons? And we haven't addressed that issue, but I think it's an issue we are facing right now. We need to do something about.
That's a great point. And actually, Elsie, who is one of the the folks that are listening in, is asking that question of all the panels. Other than healthcare, that's the health profession. What are we doing about prevention and health promotion, and whether it's training the health professions, but I will also say other workers, whether it's the volunteers in the community or folks that are unskilled. I mean, how do we focus on prevention? Because ultimately, I do think that's that's where it's all at. So just curious, since she's asking, and I think you're talking about it, Vibeke, but how do we, I guess, get that knowledge out to folks in education, educated, but also folks that touch people that can actually influence how they educate them, the conversations they have with them, and a lot of that is about changing behaviors, right? As I think somebody said earlier. So just curious about that. How do we get that, knowledge out? I mean, I know in the U.S. I can say that, it's really hard because prevention has not been the focus. It's all around episodic care. I would say that is one of the weaknesses of the U.S. health system. An ounce of prevention can do a lot, but not if you don't focus on it. So just curious from what your perspective, just to get to Elsie's question about prevention. How do we make sure that happens in education settings?
The health professional education that I have been involved with has had always strong areas of prevention and promotion. The issue has been that the funding for services and the models of care that we have put in has diminished a lot of the promotion and health prevention areas. Apart from, I would think, the public health kind of arena where we have in the communities, but in hospitals and even in primary care, there's so much perverse incentives with the funding that I think it kind of diminishes the work that you can do in prevention. And this is part of the issue. I think it's a policy issue at a government level and a funding issue. We need to do a lot more to strengthen. And this is a lot more than just vaccinations and immunisations. This is behavioural things, and so I think we have to look at that, because I think it's not, Alamata, I remember doing this kind of, primary care 30 years ago, and so it's not that it's not been around. It's just that we have a system that is concentrated on the sick, and it's not concentrating on keeping people well. So, continuing education for health professionals, I think, is important, that they have access to the programs and the latest research and information, because otherwise, the system just gobbles you up with dealing with the tsunami of diseases and disorders, and the health professionals themselves, even though they know, they need reminding and they need space, and that means that they need to have service development models that encourage more prevention and promotion, education of consumers, health literacy. Health literacy is just not done enough. There's not enough health literacy in the system for consumers to have control over their own decisions and understand the systems, and they are vital to get the balance right so that we can get more prevention and promotion.
So that sort of brings me to the last question for our speakers. I think you started to talk about it, which is policymakers. And I've spent the last 25 years working, primarily in the U.S., which is a system of both the federal government, but also 50 states and territories. So you think about it as 50 countries you have to influence. And I've also worked globally. And I would say that, how do we encourage government policymakers? But I think there's a more foundational, more fundamental question, which is, I think you said it, Frances, is early intervention, as we talked about earlier, prevention, the health promotion, all that stuff is not visible. And the outcomes of, if you do, prevention, and even if you train the whole workforce, it's going to take you 10, 20, 30, 40 years sometimes to see the impact on that. Well, policymakers, what's the issue? They are elected. And I see that now, the struggles of the healthcare systems really all over the world, where we want quick fixes, or we reinvent our healthcare system or our healthcare government, every 5, 10 years. Well, that's not enough to see if what you started works. So it's sophisticated, and I would say this conversation we've had, I would say, unless you're part of the network, it would be hard just to jump into understanding everything we're saying, because you really have to have been in this, seen all this from all the different angles. So how do we encourage? I would say, how do we actually educate government and policymakers around what's needed in terms of both the teams that are needed, setting standards and criteria, but also how do we, make them, take some wins for prevention, because I think that's or early intervention, or sort of the healthy lifestyles, because again, that's not visible. It's a lot visible if you put money into an issue of diabetes and you see an impact right away, or if you put money into cancer prevention, you get cancer research and you have an outcome right away. That's a quick return versus some of this long term. So just curious, because I think that is what we call in the U.S. the elephant in the room, which is probably the hardest to change. How do we get our policy teams on board in countries and around the world to get us to support what we're talking about?
I think that health economics can play a big role in that, because of the fact, as you were saying, those who make the policy, they want to see an issue and they want to resolve it right then and there, which is what you do when you cure something. But looking for them to make them realize that prevention and health promotion would work, I think health economics can play a big role, about the fact that if you can provide them with the numbers, the costs that it costs to a community, to a country, of taking care of all those diabetic people and all those people who have lung cancer, and all of the costs that come with the morbidity and the mortality, the fact that they're not working, that all of that costs come together, and then putting that into a budget, looking at what we can do if we do correct prevention and promotion, giving it enough time. I think health economically, you would definitely be able to see the difference, and that would help in some way, not all of it, but it could help as one of the points to convince those who are not there, who are not convinced that promotion, because that's the issue. We're all convinced that health promotion and prevention is key to make sure that we have a healthier population, but they don't see it that way. So I think the health economics being involved could help on that part as well.
Frances?
I agree. I think the only way is to get them to understand the money. I have to say, when I've worked with politicians and senior people, you can talk about, what benefit it is for the person and better functioning life and prevention, but you've always got to end up talking about dollars. And I think an important part of the health professional team in the future is a health economist. I think that politicians and others in decision making often don't read, so they're not reading the Lancet, they're not reading the peer-reviewed journals that talk about the evaluation studies, and what it means is, if you invest here, the opportunity cost, and then how much money you can save in countries if you, they understand immunisation. We've got that down off pat, so they know if they promote immunisation, you can save X amount of dollars, and people getting polio and malaria and other things like that. But we need to actually get them to understand what it means if we can reduce the amount of obesity, if we can reduce the amount of anxiety disorders, And the health economists are now starting to put dollar figures. They talk about burden of disease. They talk about if you don't deal with this, you're going to have to build more hospitals. You're going to have more renal dialysis facilities. So I think we have to get more of that kind of information and fact sheets, and we have to evaluate the areas that are working well. We have to evaluate the prevention and health promotion strategies that are working well, and we need to disseminate them across countries and internationally. So in Scandinavia, which we know does this better than many other countries, we often use those and say, look at these pilots, look at this is what's going on, and we need to get those in front of our politicians. But we also have to talk constantly about money. People don't seem to respond unless it's money or kind of high-profile things that's going to affect their election campaign, as we know, teams. So the more we can do to get factual information, short and sweet, in front of our decision makers, and also submissions. We need health professionals, nursing organisations, all our professionals to submit to when there's policy debates, when they're calling for discussions, when they want their documents reviewed. You know, a lot of us, we get so overwhelmed. We see these documents and we say, oh, we'll get round to responding, and we never do. And it's really important that we have organised groups, advocacy groups that can respond to them, because a lot of them, you know, we've got the farmers and we've got the other organisations who are there to protect their own industry. They'll promote drugs and things which may not be the answer. You know, we know that bariatric surgery has had a drastic effect on obesity of obese individuals, and it prevented them from diabetes. But we still promote lots of other drugs, and you know, so there's got to be a good balance. And I keep going back to the consumer. Patients need better information. They've got to be lobbying, and we need to support the health professionals, consumer groups, and what they're saying.
What I agree, and Elsie, you know, again points out that, you know, how do we communicate not only the knowledge on the consumer side, but also to our policymakers, so they, you know, to make them understand. I think health economics, you both mentioned it, the two of you, and I think that's key. And how do we give people points for saving money 5-10 years? It's all about how do we position our policymakers that are elected officials, and I think in the world. And then Ken has a question. So what's the role? And I think this is a great topic. So I'm just encouraging Aricia and Nick to think about that for the conference. He's asking, what's the role of, you know, international organizations like WHO and other organizations to promote sort of interdisciplinary collaboration in the provision of healthcare services. So I think that could be an excellent topic. You know, both Ken is suggesting it, I'm sure others. Really, how do we, you know, how does in a place like the network to take up this kind of conversation and maybe invite in sort of in a panel some of these key players at the global scene, and maybe also bring in some people, you know, from other governments that have done it. So I think that's a great, you know, potentially looking at. I think one of the questions is also, how do we promote autonomy in nursing practice? One of the things that we talked about before we started this is that at least Vibeke and the four of us have been involved in nursing autonomy at all levels, of the APN level, and really a seminar around how to do that. So that might be sort of some good pointers. So with that, we've got about 2 minutes left before we end. So any last minute comments for our excellent you know, panelists? Aricia, do you want to say some last minute comments?
Yeah, sure. I think it was an invigorating, stimulating discussion. I think we cracked some of the key points. I think there's still a lot of work to be done, but I think moving forward, looking at the key points that were evolved from this, looking at the team of the future as we were discussing it, and seeing how we can assist in that. I think the network can also play a big role in that because of the fact that it's known to be an interdisciplinary, multicultural, and intergenerational platform, a community of all of those. So we have many of those key players in there. So that's the value of the network, is assisting and helping create that. So I think there's a an interest in looking towards the future, and if we can see the WHO document looking towards either conferences or just other discussions or panelists looking at if we can revisit that document and taking all of these key players like yourselves here on the panel evolve and look at what we could do to help structure that, including as well the topic that Ken brought up, which is a key point because we all want to be doing it, but I think in developing countries it is another issue, and there's another set of cultural and political difficulties that we have overcome in countries like in Belgium because we have the luxury of having that here. And I think it's interesting to evolve those from those countries to see what we can do in help and assist so that we can create the things that are working here that we can help create there. So thank you for having me. It's great.
Vibeke, any last comments, Vibeke?
Yeah, it has been such interesting discussion here, and I look forward to keep on doing it. But I also think it has to do with putting people back into the main issue for the healthcare, like for the world. What is it actually we should do for our population? And nurses contribute, but what is it actually we can do on that kind? And I think we need to put our chairs to the table and make it worldwide, that we need to have a change in how money is spent, how life are not spent the right way, because a lot of things is actually not giving their abilities. And I'm so concerned about the future for the health for the whole world in many ways, like climate changes and what are we doing to each other. So I mean also how can we put back, so money talks, but it should be talking on the well-being of the citizens of the world and the countries, instead of, money talks for industry or doing a lot of other things. So I mean, how can we actually make that a movement to get back on it, that money can be spent in a wiser way to keep the population healthier?
And that goes back to that resilience comment I think Francis started out with. So Francis, any last comments?
Yeah, I mean, I think what we know is we can't continue to do what we're doing. We haven't got the workforce, and WHO's 2030 and OECD reports are very clear. We haven't got the workforce to deliver on all the need. We also can't keep affording to spend the money we're spending. In many countries, they are in severe crisis with healthcare spending. So we know that the model has to change, and that the consumer is a large part of that model, i.e. that the needs of the consumer must come first, not the needs of the providers. The role of the consumer in their data and information, and their role in understanding and their ability to determine how care is delivered to them is going to be bigger. And we also have technology. And technology, we know, is now coming in thick and fast. And that's going to also change some of our roles, which we are still coming to grips with. And we need to understand that more. So there's a whole lot of areas which is still unknown, and it's a new frontier on. And we need to be able to have greater discussions, and as we've mentioned, the network. But what's important is that the consumer or the patient or the person has to be in the middle of it all. We cannot go along as professionals, and as particularly as nurses and midwives, without that strong relationship with our patients and consumers. We don't have a role without them. And I think at times we often, debates get into other areas, and what it should be about is how can we keep providing the support, the care, the treatments for patients and consumers the best way possible, and making sure that as many people aren't disadvantaged in the process, because I'm always conscious that we're here for all. We're not here just for the rich consumers, we're here for everyone.
Very nicely said. So I would say, Aricia, to be continued, you and Nick, I mean, you have a tall order, continuing the discussion. So I just want to thank our excellent panelists. I thought it was a great and rich discussion, and let's continue it. I would, maybe put some of these suggestions we have into a structure of some sort, but it's certainly a discussion to be continued. So thank you, everyone.
Thank you.
We'll see you hopefully at the conference this summer.
Okay. Bye.
Bye.
Thank you. Bye.
Bye.